Introduction to Wound Management. Fundamentals of Effective Wound Care. Wound management is a systematic approach to assessment, treatment, and monitoring of wounds to promote optimal healing and prevent complications. Understanding the wound healing process is fundamental to effective wound management. Wound healing progresses through three main phases. The inflammatory phase involves blood clotting and immune response in the first 5 days after injury. This is followed by the proliferative phase, where new tissue forms over 3 to 21 days. Finally, the maturation phase involves tissue remodeling and can last from 21 days to over a year. Understanding different wound types is essential for choosing appropriate interventions. Wound types are classified into several categories. Acute wounds have sudden onset and typically progress through normal healing phases. Chronic wounds persist for more than 30 days and may stall in the inflammatory phase. Surgical wounds are clean, controlled incisions created during medical procedures. Traumatic wounds are irregular and often contaminated with debris or bacteria. Effective wound management addresses 4 primary goals. The primary goals of wound management include preventing infection by reducing bacterial load and contamination, promoting tissue regeneration by creating an optimal healing environment, minimizing scarring to maintain tissue integrity and appearance, and restoring function to allow return to normal activity and movement. In summary, effective wound management requires thorough assessment of wound characteristics, understanding of wound healing physiology, selection of appropriate interventions, and ongoing monitoring and evaluation. This concludes our introduction to wound management. Establishing the foundation for the specialized techniques we'll explore in later sections. Proper wound assessment is the foundation of effective wound management. Let's explore the key parameters that should be evaluated during wound assessment. First, document the wound's location, including anatomical site and functional impact. Next, measure the wound's dimensions, length, width, and depth in centimeters using a consistent technique. When measuring a wound, always use the longest length and width at perpendicular angles. Depth should be measured at the deepest point. Assess the wound's appearance, including tissue types present, color, and wound bed characteristics. Document exudate characteristics, including amount, type, and any odor. Identifying different tissue types in the wound is crucial. Necrotic tissue appears black and requires debridement. Slough is yellow or tan fibrinous tissue. Healthy granulation tissue is red or pink and indicates healing. Epithelialization shows new skin growth. Assess the condition of the skin surrounding the wound, looking for maceration, erythema, induration, and temperature changes. Monitor for signs of infection, including increased pain, redness, warmth, swelling, purulent drainage, and odor. Document the wound's etiology, such as pressure, venous, arterial, or diabetic origin, as well as its duration. Consider the patient's overall health status, including comorbidities, medications, and nutritional factors that may affect healing. Document wound assessment using standardized tools and forms. This helps track healing progress over time and ensures consistent evaluation by different healthcare providers. Remember these key points. Assessment forms the foundation for all treatment decisions. Document consistently using standardized methods, and reassess regularly to track healing progress. Creating an optimal wound healing environment is essential for successful tissue repair and regeneration. This involves maintaining cleanliness, appropriate moisture, proper temperature, regular assessment, and using suitable dressings. The ideal wound environment is appropriately moist, not too wet or too dry. When a wound is too dry, cell migration is restricted, and tissue can become dehydrated and damaged. An optimally moist environment promotes cell migration and proliferation. However, excessive moisture can lead to maceration of the surrounding skin, which weakens tissue and can lead to further breakdown. Temperature also significantly affects wound healing. Wounds heal optimally at body temperature, around 35 to 37 degrees Celsius. When temperature drops below this range, cellular activity slows, reducing the healing rate. Conversely, temperatures above the optimal range can damage cells and impair healing. This is why maintaining normal body temperature around the wound is critical for optimal healing. Selecting the appropriate dressing is critical for maintaining an optimal wound environment. Different wound types require different dressing properties. Hydrogels add moisture to dry wounds. Foam dressings manage moderate drainage. Alginates absorb heavy exudate from highly draining wounds. Film dressings help maintain moisture in superficial wounds while allowing visualization. The optimal frequency for dressing changes varies based on the wound's healing phase. In the inflammatory phase with high exudate, daily changes may be needed. During the proliferative phase with moderate drainage and granulation tissue formation, changes every 2 to 3 days are often appropriate. In the remodeling phase with minimal drainage, dressings may be left in place for 3 to 7 days to avoid disrupting the healing process. To create an optimal wound healing environment, remember these key points. Maintain balanced moisture levels. Keep the wound at body temperature. Select appropriate dressings based on wound characteristics. Adjust dressing change frequency according to the healing phase, and regularly reassess the wound to adjust care as needed. Transparent film dressings are a valuable tool in modern wound care. These are semi-permeable, adhesive sheets that allow oxygen exchange while creating a barrier against bacteria and external fluids. Transparent film dressings offer several key benefits that make them valuable in wound care. They allow oxygen exchange while blocking bacteria, which supports healing and prevents infection. Their transparency permits wound visualization without removing the dressing, reducing disruption to the healing process. These dressings maintain a moist wound environment, which accelerates healing and reduces scarring. Finally, they protect the wound against friction and provide a waterproof barrier during bathing. Let's review the proper application technique for transparent film dressings. First, cleanse the wound thoroughly and dry the surrounding area. Next, carefully remove the protective backing from the dressing. Position the dressing over the wound without stretching it. Gently press down on the dressing, working from the center outward to secure the edges. Remember, do not stretch the dressing during application, as this can create stress on the skin. Let's examine when transparent film dressings are most appropriate and when alternative dressings should be considered. Transparent film dressings are ideal for superficial wounds, partial thickness wounds, protecting high-friction areas, and securing intravenous catheters. However, they should not be used on infected wounds, heavily exuding wounds, deep wounds, or on fragile skin where removal might cause trauma. Transparent film dressings create an optimal environment for wound healing by maintaining moisture while allowing oxygen exchange. Over time, the moist environment under the film promotes faster epithelialization and reduces scarring. Transparent film dressings provide an excellent option for many wound types when selected appropriately and applied correctly. Hydrocolloid dressings are an important tool in modern wound management. Hydrocolloid dressings contain gel-forming agents such as carboxymethylcellulose, gelatin, and pectin. They typically consist of 2 main layers: an outer polyurethane film that's waterproof and an inner layer containing the gel-forming agents. When applied to a wound, hydrocolloid dressings interact with wound exudate. The gel-forming agents absorb the exudate and transform into a gel, creating a moist environment that promotes healing. Hydrocolloid dressings offer several important benefits for wound management. They provide thermal insulation, maintaining optimal temperature for healing processes. The waterproof outer layer creates an effective barrier against external bacteria and contaminants. These dressings can remain in place for 3 to 7 days, reducing the frequency of dressing changes and disturbance to the wound. When removed, the gel doesn't adhere to the wound bed, minimizing trauma to newly formed tissue. Proper application of hydrocolloid dressings involves several key steps. First, select a dressing that extends 1 to 2 centimeters beyond the wound edges. Clean the wound with saline or prescribed solution and ensure the surrounding skin is dry. Carefully remove the backing without touching the adhesive surface to maintain sterility. Apply the dressing without stretching, starting from one edge and smoothing toward the opposite side. Gently press and smooth the dressing to ensure proper adhesion to the surrounding skin. When applying hydrocolloid dressings, keep these important tips in mind. Let's examine the appropriate clinical applications for hydrocolloid dressings. Hydrocolloid dressings are excellent for partial thickness wounds, granulating wounds, and early-stage pressure ulcers. They work best with minimal to moderate exudate and can be used for superficial burns. However, these dressings should not be used on infected wounds or those with heavy exudate. They are also contraindicated for third-degree burns, fragile skin at risk of tearing, and wounds requiring frequent assessment. When using hydrocolloid dressings, there are several important clinical considerations to keep in mind. As the dressing absorbs exudate, a yellow or brown gel forms underneath. This is normal and not a sign of infection. Change the dressing when the gel is visible 1.5 to 2 centimeters from the wound edge, or if the dressing begins to lift. Initially, the wound may appear to enlarge as necrotic tissue is autolyzed. This is an expected part of the debridement process. Document the appearance of the gel and wound margins with each dressing change to monitor healing progression. If signs of infection develop, such as increased pain, redness, or purulent discharge, discontinue use and reassess the wound. Wound irrigation is a critical component of wound care involving cleansing a wound with fluid to remove debris, bacteria, and dead tissue. This process is essential for proper wound healing and preventing infection. Effective wound irrigation requires the right amount of pressure. The optimal pressure range is between 4 and 15 psi, pounds per square inch. This pressure is strong enough to remove debris while avoiding tissue damage. Too little pressure won't effectively clean the wound, while excessive pressure can drive bacteria deeper into tissues. For proper wound irrigation, you'll need the right equipment and solutions. A 35 milliliter syringe with a 19-gauge needle achieves the optimal pressure of 4 to 15 psi. Commercial irrigation devices are also available that deliver consistent, appropriate pressure. For irrigation solutions, sterile saline is most commonly used, as it's isotonic and non-toxic to tissues. For infected wounds, your healthcare provider may prescribe antimicrobial solutions. Always use sterile solutions warmed to body temperature when possible to enhance comfort. When performing wound irrigation, proper technique is crucial for effective cleansing. Direct the flow from the least contaminated area to the most contaminated area to prevent spreading bacteria across the wound. Hold the irrigation device at the proper distance, about 1 to 2 inches above the wound. Irrigation should continue until the solution runs clear, indicating that debris and bacteria have been effectively removed. Proper wound irrigation provides several important benefits. First, it reduces bacterial load by up to 90%, significantly decreasing infection risk. It effectively removes debris and foreign material that could impede healing. Irrigation promotes an optimal healing environment by maintaining tissue moisture and cleanliness. It prevents infections and other complications that could delay recovery. And finally, irrigation is absolutely essential for contaminated or infected wounds to ensure proper cleaning before dressing application. Remember, effective wound irrigation combines the right pressure, appropriate solution, and correct technique to optimize wound healing and prevent complications. Debridement is the removal of non-viable tissue from a wound to promote healing. Effective debridement accelerates healing by removing barriers to tissue regeneration. The process transforms a wound with necrotic tissue into one ready for healing. There are 5 main methods of debridement used in wound care. Surgical or sharp debridement involves using scalpels, scissors, or other sharp instruments to physically remove non-viable tissue from the wound. This is the fastest and most selective method, but requires a skilled practitioner and may require pain management for the patient. Mechanical debridement uses physical force to remove non-viable tissue from wounds. This includes using wet-to-dry dressings, where gauze adheres to dead tissue and removes it when the dressing is changed, as well as wound irrigation with pressure. While effective, mechanical methods are less selective than surgical debridement and may damage healthy tissue. Autolytic debridement harnesses the body's own enzymes to naturally break down dead tissue. This method uses occlusive dressings to create a moist environment that promotes the body's natural healing processes. While highly selective and painless, autolytic debridement is often slower than other methods and may not be suitable for infected wounds. Enzymatic debridement uses topical enzyme preparations to break down specific components of necrotic tissue. These preparations are selective for certain tissue types and are easy to apply, making them useful for patients who cannot tolerate other debridement methods. However, enzymatic debridement may require daily applications and can be more expensive than other options. Biological debridement, also known as maggot therapy, uses medical-grade fly larvae to selectively remove dead tissue while preserving healthy tissue. This method is highly selective and particularly effective for complex wounds or those with antibiotic-resistant infections. However, despite its effectiveness, biological debridement may face psychological barriers from patients and healthcare providers. The selection of debridement method depends on several critical factors. Surgical debridement offers the fastest results with high selectivity, but causes more pain and requires skilled practitioners. Mechanical methods are moderately fast but less selective and may damage healthy tissue. Autolytic debridement is the slowest but highly selective and painless, making it suitable for many patients. Enzymatic methods provide moderate speed and selectivity but can be more expensive. Biological debridement offers excellent selectivity with moderate speed and low pain, but may face acceptance challenges. When selecting a debridement method, clinicians must consider several key factors. These include wound characteristics like size, depth, and location, patient factors such as pain tolerance and comorbidities, available resources and expertise, and the balance between speed and tissue preservation. The choice of debridement method must always be individualized to optimize patient outcomes while minimizing risks. Proper bandaging serves 4 key purposes in wound management. It provides protection for the wound, secures dressings in place, applies pressure when needed to control bleeding, and supports the surrounding tissues. For extremity wounds, there are 2 main bandaging patterns, spiral and figure 8. When bandaging extremities, always start at the distal end, that's farthest from the heart, and work your way proximally or toward the heart. Each layer of bandage should overlap the previous one by 50%. This ensures proper coverage and helps the bandage stay in place. Finally, secure the end of the bandage with tape or clips to prevent it from unwrapping. When bandaging joints like knees, elbows, or ankles, a figure 8 technique is most effective. The figure 8 pattern alternates above and below the joint, crossing over the joint in the middle. This technique allows for limited joint movement while maintaining coverage, even when the joint is flexed. The figure 8 pattern also provides stability to the joint while still allowing some range of motion. For wounds on the trunk of the body, different bandaging approaches are required. Circumferential wraps are commonly used for securing dressings to the chest or abdomen. For areas that require frequent dressing changes, specialized adhesive products or Montgomery straps may be more appropriate. When bandaging the chest, always consider the impact on respiratory function. The bandage should be secure without restricting breathing. After applying any bandage, always check circulation to ensure the bandage isn't too tight. Check distal pulses to ensure adequate blood flow past the bandaged area. Assess skin color. Look for paleness or bluish discoloration, which may indicate restricted blood flow. Check the temperature of the skin distal to the bandage. Cool skin may indicate compromised circulation. Test sensation by asking the patient if they can feel light touch distal to the bandage. If any signs of compromised circulation are present, adjust the bandage tension immediately. Proper care of sutures and staples is essential for preventing infection and promoting optimal wound healing. Clean the wound and suture line gently with the prescribed solution. Use a swab and clean from the center outward to avoid introducing contaminants into the wound. Apply prescribed topical agents if indicated by your healthcare provider. Use a clean applicator and apply sparingly to avoid excessive moisture. Choose the appropriate dressing based on wound characteristics. Dry wounds with minimal drainage benefit from transparent films, while moderate to heavy drainage requires more absorbent dressings. Monitor the wound regularly for signs of infection, excessive tension, or dehiscence. Warning signs include increased redness, swelling, pain, discharge, foul odor, or if the wound begins to open. Sutures and staples are typically removed after 7 to 14 days, depending on the wound location and patient factors. Facial sutures may be removed earlier, within 3 to 5 days, while joint sutures often remain for 14 to 21 days. Removal must be performed by a healthcare professional using sterile instruments and proper technique to minimize trauma to the healing tissue. Wound drains are essential devices used to remove accumulated fluid from surgical sites or wounds. These drainage systems prevent complications such as hematomas, seromas, and infections by removing excess blood, serum, and other fluids. Wound drains serve several important purposes in the healing process. There are several types of wound drainage systems, each designed for specific clinical situations. Penrose drains are simple, passive, open drains consisting of a soft rubber tube. They work through capillary action and gravity. Jackson-Pratt drains are closed suction systems with a silicone tube connected to a compressible bulb. They actively remove fluid through negative pressure. Hemovac drains are another type of closed suction system, featuring a larger collection chamber for greater capacity. T-tubes are specialized drains primarily used in biliary surgery to maintain bile flow during healing. Let's compare these drain types based on their key characteristics. Proper drain management is crucial for patient safety and effective wound healing. Regular monitoring of drainage is essential. Observe the amount, color, and consistency of drainage at least once per shift. Significant changes may indicate complications such as infection or hemorrhage. Collection devices should be emptied when they are 1/2 to 3/4 full. Always maintain aseptic technique during this process. For suction drains like Jackson-Pratt, remember to compress the bulb before reclosing to reestablish suction. Maintaining a closed, sterile system is essential to prevent infection. Avoid disconnecting drains unless absolutely necessary, and always use clean gloves when handling drainage systems. Drains must be properly secured to prevent accidental dislodgement. Use tape or specialized securing devices, ensuring there's no tension on the insertion site while still allowing for patient movement. Clean the drain insertion site according to your facility's protocol. Observe the site for signs of infection, such as redness, swelling, or unusual drainage, and apply the appropriate dressing as directed. Thorough documentation is an essential component of wound drain management. Document key characteristics of drainage, including amount in milliliters, color, consistency, and odor. Also record the appearance of the insertion site and note when the collection device was emptied. It's critical to know when to notify the healthcare provider about significant changes in the drainage system. Contact the provider if you observe a sudden increase in drainage amount, a change from serous to purulent drainage, bright red bleeding, or signs of infection at the insertion site. Vacuum-assisted closure, commonly known as VAC therapy, is an advanced wound healing technique that uses negative pressure to promote wound healing. VAC therapy is defined as the controlled application of subatmospheric pressure to local wound environments, promoting healing in acute and chronic wounds. VAC therapy works through 4 key mechanisms. First, it removes wound exudate efficiently. Second, it reduces edema by removing excess interstitial fluid. Third, it increases blood flow to the wound area by creating micromechanical strain. Fourth, it promotes granulation tissue formation by stimulating cell proliferation and angiogenesis. The VAC system consists of four essential components: a foam dressing cut to the wound size, an adhesive drape that creates an airtight seal, tubing that connects the foam to the pump, and a vacuum pump that creates negative pressure. Let's walk through the VAC application procedure. First, cut the foam dressing to match the size and shape of the wound. Then, place the foam directly into the wound bed, ensuring it contacts all wound surfaces. Next, cover the foam with an adhesive drape, extending 3 to 5 centimeters beyond the wound edges to create an airtight seal. Create a small hole in the drape for the tubing port and apply the port directly over this hole. Finally, connect the tubing to the VAC pump and set the prescribed negative pressure, typically between 75 and 125 millimeters of mercury. For proper maintenance, change the VAC dressing every 48 to 72 hours or as clinically indicated. At each dressing change, assess the wound for progress and ensure the airtight seal is maintained. It's crucial to monitor for complications including bleeding, pain, signs of infection, and foam adherence to tissues. With proper application and monitoring, VAC therapy significantly accelerates wound healing through these controlled, negative pressure mechanisms. Infected wounds show distinct signs and symptoms that require specialized management. Key signs of infection include increased pain, erythema or redness, warmth, swelling, purulent drainage, malodor, and systemic symptoms like fever. Management of infected wounds requires a comprehensive approach. First, more frequent cleaning and dressing changes are essential to remove infectious material. Appropriate antimicrobial dressings help control bacterial load. Systemic antibiotics may be required for deeper or spreading infections. Debridement may be necessary to remove infected tissue. Culture-guided therapy ensures appropriate antimicrobial coverage, and highly absorbent dressings manage the increased exudate produced by infected wounds. Antimicrobial dressings are crucial for managing infected wounds. 3 common types include silver-based, iodine-based, and honey-based dressings. Silver-based dressings offer broad-spectrum antimicrobial activity with low resistance risk. They're effective against biofilms and come in multiple forms, though they should be avoided before MRI procedures. Iodine-based dressings provide rapid action against bacteria and fungi. However, they may stain tissue and are contraindicated for patients with thyroid disorders. Honey-based dressings offer anti-inflammatory properties with osmotic and debriding effects. They may cause stinging on application and should be monitored carefully in patients with diabetes. Culture-guided therapy is essential for appropriate treatment of infected wounds. The process involves collecting a sample before starting antibiotics, using appropriate technique to avoid contamination, sending the specimen for culture and sensitivity testing, adjusting therapy based on results, and documenting all findings and treatment decisions. Dressing management for infected wounds requires special attention to frequency of changes and absorption needs. The frequency of dressing changes depends on the severity of infection. For heavily infected wounds, dressing should be changed every 12 hours, with careful monitoring for deterioration. Moderately infected wounds typically require daily changes with reassessment after 2 to 3 days. As infections resolve, dressing changes can be reduced to every 2 to 3 days, transitioning toward standard wound care. Always monitor for systemic signs of infection. Escalate care if the infection worsens, and document wound appearance at each dressing change. Chronic wounds often face specific barriers to healing that require specialized dressings. Alginate dressings are derived from seaweed and are highly absorbent. They convert to a gel upon contact with wound exudate, making them ideal for heavily exuding wounds. Foam dressings provide cushioning and insulation for moderate to heavily exuding wounds. They maintain a moist wound environment while absorbing excess fluid. Hydrofiber dressings absorb and lock in exudate to prevent maceration of surrounding skin. They gel on contact with wound fluid and conform closely to the wound bed. Antimicrobial dressings containing silver, iodine, or honey help manage bioburden in infected or critically colonized wounds. They provide sustained antimicrobial activity. Collagen dressings provide a scaffold for new tissue growth and attract fibroblasts to accelerate healing in stalled wounds. They stimulate granulation tissue formation. Selecting the right specialized dressing depends on the specific needs of the chronic wound. Consider factors like exudate level, presence of infection, and the wound's healing stage. When using specialized dressings, remember to monitor wound characteristics regularly. Change dressings as recommended, reassess if there's no improvement after 2 weeks, and consider combination therapy for complex wounds. Pressure redistribution is essential for preventing new wounds and promoting healing of existing pressure injuries. Prolonged pressure on tissue restricts blood flow, leading to tissue damage and wound formation. Regular repositioning every 2 hours is crucial for bed-bound patients. Proper positioning with pillows and foam wedges helps to offload pressure points and prevent tissue damage. Specialized support surfaces like foam, air, gel, and alternating pressure mattresses help redistribute pressure. These surfaces should be selected based on the patient's risk level and condition of existing wounds. Heel elevation devices completely suspend the heels to eliminate pressure on this vulnerable area. Never allow heels to rest directly on any surface for patients at risk of pressure injuries. For seated patients, pressure redistribution cushions help minimize pressure on bony prominences. Regular weight shifts every 15 to 30 minutes are essential for preventing pressure injuries in wheelchair users. Regularly assess the effectiveness of pressure redistribution strategies by checking skin for redness or damage. Evaluate pressure redistribution equipment to ensure it's functioning properly. Adjust strategies based on ongoing skin assessment findings. Document all findings and interventions to ensure continuity of care. Remember, continuous assessment and adjustment are key to effective pressure redistribution in wound care. Nutritional support plays a crucial role in wound healing. Optimal nutrition is essential for tissue repair and regeneration processes. Several key nutrients are vital for effective wound healing. Protein is required at 1.2 to 1.5 grams per kilogram of body weight daily to support tissue repair. Vitamin C is essential for collagen synthesis, which provides structure to the healing wound. Zinc supports cell proliferation and immune function, both critical for healing. Vitamin A promotes epithelialization, the process of covering the wound with new skin cells. Adequate caloric intake prevents the breakdown of lean body mass, which can impair healing. Hydration is equally important. Patients need approximately 30 milliliters of fluid per kilogram of body weight daily. Nutritional assessment should be an integral part of wound management. Regular screening includes monitoring weight, food intake, and laboratory values to identify nutritional deficiencies. Based on assessment findings, interventions may include oral supplements, enteral feeding through a tube, or parenteral nutrition when the digestive system cannot be used. Regular reassessment ensures that nutritional support matches the changing demands of the healing wound. Patient education is a critical component of wound care management. Effective patient education improves healing outcomes, prevents complications, increases patient confidence, and reduces hospital readmission rates. Let's examine the key elements that should be included in patient education for wound self-care. First, patients need clear instruction on proper wound cleansing techniques, including using lukewarm water, applying gentle pressure, and patting the area dry. Dressing change procedures are also essential. Patients must understand the importance of hand hygiene, proper removal of old dressings, and correct application techniques. Equally important is educating patients about warning signs that require medical attention, such as increasing pain, spreading redness, and foul odor or discharge. The effectiveness of patient education depends greatly on the teaching methods used. The teach-back method confirms understanding by asking patients to explain instructions in their own words. Demonstrations are powerful tools. Show the technique first, Then have the patient demonstrate it back to you. Written instructions with clear pictures provide patients with a reference guide to use at home. Patient education should be customized to address individual needs and preferences. Cultural factors influence how patients understand and approach wound care. Consider cultural beliefs about healing and the role of family in the care process. Literacy levels vary among patients. Use simple language and visual aids when appropriate to ensure comprehension. Learning preferences differ. Some patients learn best visually, others through listening, and some through hands-on practice. Offer multiple approaches. Education is not a one-time event, but a continuous process requiring follow-up. Educational reinforcement should occur at regular intervals throughout the wound healing process. Follow-up at 1 week allows for assessment of technique and addressing initial challenges. 2-week reinforcement helps strengthen proper practices and correct any developing issues. A final assessment confirms patient proficiency and readiness for independent care. This consistent follow-up reinforces key concepts, addresses new concerns, and evaluates the patient's technique proficiency. Pain management is an integral part of wound care that improves patient cooperation and quality of life. Effective pain management involves 4 key components: assessment, pharmacological interventions, non-pharmacological approaches, and procedural techniques. Pain assessment should be conducted using standardized scales that help quantify the patient's pain experience. Regular pain assessments should be performed before procedures, during wound care, and after interventions to evaluate the effectiveness of pain management strategies. Pharmacological interventions include topical anesthetics, systemic analgesics, and anxiolytics when needed. Topical anesthetics like lidocaine and EMLA cream should be applied 30 to 60 minutes before procedures and covered with transparent film for optimal absorption. Systemic analgesics include non-opioid options like acetaminophen and NSAIDs, as well as opioids for moderate to severe pain. Time administration, so peak effectiveness coincides with the procedure. Anxiolytics may be considered for patients experiencing significant anxiety, especially during extensive wound procedures. Non-pharmacological approaches can significantly reduce pain perception and anxiety during wound care. Distraction techniques include conversation about pleasant topics, guided imagery, counting exercises, and engagement with videos or devices. Relaxation techniques such as deep breathing exercises, progressive muscle relaxation, and mindfulness meditation can help reduce tension and pain. Other approaches include music therapy, timing procedures when the patient is well rested, repositioning for comfort, and making environmental adjustments. Procedural techniques focus on minimizing pain during wound care through gentle handling, appropriate dressing selection, and proper removal techniques. Gentle tissue handling involves using appropriate tools and techniques, supporting surrounding tissue, minimizing pressure, and maintaining stable wound temperature. Appropriate dressing selection can significantly reduce pain. Consider non-adherent contact layers, silicone-based dressings, hydrogels for dry wounds, and avoid adhesives on fragile skin. Pre-soaking adherent dressings before removal is essential to minimize pain. Saturate the dressing with saline or water, allow time for complete saturation, remove in the direction of hair growth, and consider silicone-based adhesive removers. The field of wound management continues to evolve with innovative technologies that offer new solutions for complex wounds. Let's explore 6 cutting-edge technologies transforming wound care today. Bioengineered skin substitutes provide a structural foundation for healing. These laboratory-grown tissues contain essential proteins, growth factors, and cellular components. When applied to chronic or complex wounds, they stimulate the body's natural healing processes and provide scaffolding for new tissue growth. Growth factor therapies involve the direct application of specialized proteins that play crucial roles in the wound healing cascade. These proteins regulate cell growth, proliferation, and differentiation, helping to jumpstart the healing process in stalled or chronic wounds. Hyperbaric oxygen therapy involves treating patients in a pressurized chamber with 100% oxygen. This increases oxygen concentration in the blood and tissues, enhances white blood cell function, and promotes the formation of new blood vessels, particularly beneficial for problematic wounds like diabetic ulcers and radiation injuries. Electrical stimulation therapy uses low-intensity electrical current to stimulate wound healing. This promotes cell migration and proliferation, increases protein synthesis, and helps restart the healing process in stalled wounds. Ultrasound therapy uses non-invasive sound waves to stimulate the wound healing process. These waves increase cell membrane permeability, enhance cellular activity, stimulate blood flow, and reduce inflammation, particularly effective for deep tissue wounds. Smart dressings represent the cutting edge of wound care technology. These advanced wound covers contain embedded sensors that monitor parameters like pH, temperature, oxygen levels, and bacterial presence. Some can even automatically deliver medications or adjust treatment based on the wound's condition, offering personalized care for complex or chronic wounds. These advanced modalities are typically reserved for complex or non-healing wounds after standard approaches have been optimized. Each technology offers unique benefits for specific wound types and should be implemented under specialist supervision to maximize healing outcomes.